Okay, welcome back. We hope you've got enough daily dose of the caffeine you need today. Okay, so we will begin shortly. Mas Yopi, can I begin? Okay. Okay, once again, welcome back. So, after having the coffee break, without wasting any more time, we have our fourth and for last speaker on the cancer panel for today ready. Please welcome Professor Wen-Yu to the stage. Okay, good morning, Professor Hu. We have 30 minutes on the lecture, and you can begin now. Thank you.
Okay, good morning, everyone. I'm honored to have the opportunity to share my own experience in palliative care, especially in cancer care. So the topic is palliative care in developed and developing country. Initially, we know when we care the patients, we know we care the patient is a whole person. Yes, no? Yes. The whole person, my means is when the person lived in the environment, the inner environment include the system, organ, tissue, cell, molecular, and so on. Like such as previous, every lecture would like to provide some gene therapy or target therapy or cell therapy. This is belongs to traditional Western medicine. So the other belongs to physical and biological science. But we know the person will live in the out environment. The out environment include family, community, subculture, culture, and universal every country. So this belongs to social science. Yeah. So today, I think everyone come from different discipline to learn how to interdiscipline, collaborative together. So we know the nursing care, we always emphasize the total care for the whole person. Okay, so I think the whole person means is the patient include body, mind, and the spirit. This is the whole person. So we have to give the patients individual care and unique care and holistic care. Why? Because the person lived in the environment, social environment, or cultural environment. They are lived different family, and then we know everyone come from different family enter to the hospital. Everyone is very unique and special. Yeah, very different. So from birth to death, and sometimes the patients treatment in medical center or in community. The patient's health stage from health promotion and disease treatment or dying phase. So we know if when the patients get the disease, when he enter to the hospital, he receive many treatment, such as advanced treatment, like as target therapy or gene therapy or cell therapy. But sometimes the cancer patient cannot to cure. If the patient cannot to cure, cannot prolong survival, the health is not survival. The patient enter to the terminal. So the patient very total suffering. The total suffering include the pain, physical symptom, or psychological distress, or social difficulty, or spiritual problem, or cultural issue. So these factors always affect the patient's suffering. So we know, like as oral cancer or buccal when the patient enter to the terminal, they are suffering by the patient. They may be I think. So we would like to care the patient, take the patient, give them total care. The aim is to get the good days. So the palliative care we would provide the patients include patient's care include emotional needs, practical needs, or physical needs, psychosocial needs, information needs, and the social needs. I think it is a total care. When the cancer patient get the cancer, they receive maybe the cancer could be surgery or chemotherapy, radiotherapy, psychotherapy, chemotherapy, any advanced therapy, such as the clinical trial. Because sometimes the terminal patients, when they are in cure, the physician maybe suggest the terminal patient to receive another clinical trial. The clinical trial from the Europe or Asia or USA gradually moved into Asia. So we know these 3 days, there are many physicians mention clinical trial or advanced treatment. I think the purpose or the goal of the treatment is to cure the patient or prolong the patient's survival. Okay, so but we know in Taiwan also there are many clinical trials in Asia. This is the leading country, and most of it belongs to phase 3 and phase 4 research. So in National Taiwan University Hospital, there are many research in our hospital. Totally about 2,000 research per year in our hospital. So the patients may be received advanced treatment, but we know every patient's the disease trajectory, they will receive the active cancer treatment, and then clinical trial, or finally the patient is critical. Maybe they have to receive CPR. Yeah, and so on. So we know, but we know when the patients enter to the terminal stage, maybe they have the opportunity to receive the clinical trial. Not everyone have the opportunity to receive clinical trial. So if the patient have the opportunity to receive the advanced treatment, and then we don't lose the opportunity of the survival. But if the patients receive the advanced treatment or the clinical trial or gene therapy or target therapy, maybe they cannot curative. And then we have to let the patients to do grasp the good days. Okay, so I think it's very important. What is the good days? The good days is include 5 indicators. The awareness the days, and the acceptance the days, and the propriety, and the timeless, and the patient's comfort. This is 5 indicators. So we would like to let the patient, if the patients enter to the incurable phase, and then how to let them get the good days. So the topic is very different from before you get many message or information how to cure the patient, how to care the patient, treatment the patients. Now I will share some how to provide appropriate care for the terminal patients, because those advanced treatment is ineffective. Okay. So when the cancer cell cannot be controlled anymore, such as buccal CA or breast CA, or many malignant cancer wound, the smell is not good, and the patient is painful, and the suffering from social factor or spiritual factor, many different factor will affect the patient's suffering. Most of the people in advanced treatment, maybe when they are critical, they was sent to the ICU. Yeah. So how to provide appropriate treatment for the terminal patient? So where is the patient? Do you find? Where is the patient? Yeah, here. The hand, the finger. So, when the patient, when they enter to the dying, the patient would like to communication or say something to their family or to their good friend, their husband or their parent. But we know finally most of people around by the machine, by the ventilator and on trachea, so they can communicate with any more. So what is the appropriate care for the patients when the patient enter to the end of life, when their disease cannot curative? So I think we have to reflection about the issue. Yeah, so I think maybe the cancer care continue from we put to prevention and treatment and diagnosis and treatment and the survivorship. Finally, maybe most of, I think over health, the patients will enter to the end of life. Yeah. So we how to take care of the patient in end of life. This is a new model, integrate palliative care into our traditional care. The means is when the patient gets the cancer diagnosis, and then the palliative care gradually enter to the medicine treatment. So not just when the patient incurable, and then we change to into palliative care. The palliative care may be enter to the treatment earlier from the diagnosis. So how to put the integrate the palliative care into the cancer treatment process? Do you know when the patient get the diagnosis of the cancer, if the patients enter to the end of life, and we care the patient not focused on the cure, we transfer to the care focused on the care. So from cure to care, this is a transition phase from our mind. So we have to open our mind to receive the reality, because the patients from the acute to the diagnosis to the final when he entered to the death, and after when the patient is dead, the family bereavement care is also very important. So not the patient is dead, the care is completed. So the bereavement care is also continue. So this belongs to palliative care. But we know every woman with different disease have different style dying process. For example, the patient is COPD or heart failure or renal failure. When they are dyspnea, they come to the hospital or emergency room. he do the tracheostomy, and then get better, and then come back home. And the next time he also dyspnea, and then come to hospital. And the second trachea operation and the surgery, and then come back. And one time more and more, the patient's dying. The cancer patients receive the chemotherapy. Maybe sometimes the chemotherapy many cause. If the cancer treatment is ineffective, and then patients gradually to death. The elderly, such as frail elderly, they gradually, slowly, and the slope is very slow, and dying. But sometimes the young man to take ride a bicycle, get the accident, maybe immediately to face the death. So different disease, different dying process. So we have to face the situation when we are behave physician or nurse. Okay, so the patient and the family will encounter many different health problems and ethical dilemma during the disease trajectory, from diagnosis stage, treatment, refractory, and life and dying process. They would like engage in dying preparation earlier and die at home to achieve good days. So there are many research find that the patient would like to die at their preference, their preferred place. What is the preferred place? Most of at home, yeah. But the palliative care in the community is very less, so it's not enough. So the patient always die in hospital, yeah. So this is the dilemma. So we would like to provide the seamless care. So we create palliative care nurse and palliative home care nurse and nurse practitioner and palliative care care nurse and the navigator or case manager to help the patients to smoothly to transfer different stage. Okay, so there are 5 blessings in Taiwanese culture. Do you know the last blessing? What is the last blessing? Have anyone to know? The last blessing, what is the last blessing? Have anyone to know? The last blessing is good days. Yeah. So, but even though we would like to get the last blessing is good days, but when the Happy New Year, the parents always blame the children, don't to talk the death. So this is a taboo. So when the patient enter to the dying process, the physician don't hesitate to communicate with the patient with the death issue, the dying issue. So we have to respect the patient's wish, but we have to communicate with the patients. So we know we would like to achieve dignity health or perfect days or peaceful days. We from the several months or several 48 hours, 8 hours till the death. So the dying process is a process, not is a status. So we have to give them many comfort care for them. Okay. So we know today we would like to share the palliative care in developed and developing country. So now we depend on the world economy GNI indicator to divide it. How to divide the developed country and the developing country. There are many indicators depend on the GDP, GPI, or level of industrialization and the general standard of living, and so on. So the developed country is often used interchangeable with industrialized country or first world country. The developing countries is also interchangeable with middle income, lower middle income or low income country or third country, world country. And the other type is undeveloped country. So what is developed country? The developed country, there are several indicators. I think maybe is the high level of economic, social, technology advancement. So the highly diverse economy with a strong focus on service industry and such as healthcare and technology. So there are many indicators for the developed country. I think most of it include economic or women working and high level education. Yeah. So the GDP depend on the GDP. Sometimes some organization use the GDP to divide the developed and the developing country. For by the GDP, there are 15 countries are considered developed, 9 are considered developing, and 1 is considered in transition by the GDP. Or by the GNI is the different. The country sometimes could to be changed. So I think the most of use the HDI indicator. The HDI indicator include many factors in here. So we know we depend on the HDI 2021. There are the 3 most developed countries in the world with a HDI score of 0.96. The 3 is New Switzerland and Norway and Iceland. Yeah. According to the UN in 2023, 36 countries were considered developed. All developed countries were located in either North American, Europe, and the developed Asia and the Pacific. Okay, so what is a developing country? We say the developing country is lower income and the lower standard of living or lack of access to modern technology, logic. So, or lack of job, or clean drink water, education, and so on. So, according to the UN, I think this is the developing and the developing countries map. So, all developing countries were located either North American, Europe, or developing Asia Pacific. The developing countries were located either Africa, Asia, or Latin American or Caribbean. So we know if we know the definition of develop and developing, and we to try to understand how to develop the particular in different country. Maybe depend on every country's condition. So the community health worker, this is a systemic review paper. We know the final result through the 13 original study in Africa country and India. We find that the community health workers to have a role in raising awareness and identify individuals requiring palliative care in the community. Therapeutic management of pain and the holistic home-based care delivery and the visitation, and the provision of psychological support and the spiritual guidance. So I think is the public have to the awareness by themselves. And the other result is find that it's important role in improving, providing palliative care in low-income country setting. But there are no studies conduct a formal cost analysis because due to the stigma surrounding palliative care. So everyone have the taboo to talking about the death. So the use of the community health worker to assist in palliative care delivery appears acceptable and visible gradually, but the effectiveness evaluation is still lag. Is still lag. Okay. So further study maybe we could do like as this research, and the community health worker have to provide the physical, psychological, and the spiritual care. We say the home care, the holistic care. So the particular in our NTUH, National Taiwan University Hospital, we established hospital-based hospice. The patient admit into the palliative care unit. Sometimes the patients enter to the general ward. When he enter to the terminal, he will transfer to the palliative care unit by shared care team, palliative care shared team. And then also discharge from palliative care unit or general ward. And the hospital home care nurse will visit at home. Yeah, or sometimes he have a suffering disease, suffering symptom. They will come back the clinic, palliative clinic. And then when the patient transfer to the community, the community include longitudinal long-term care facility or nursing home. Or we could to let the nurses to go to the home to provide the home care. So this is a different style community care in Taiwan. And also we will receive some help resources from the NGO or government or social well resources to help the patients die at home peacefully. So we will consideration about the important consideration for developing the content of community health worker training program. So the education is very, very important for the community health worker. And then they could to provide the palliative care in community. The challenge and the barrier from the system level, we know 27, some journal will report the economic or the economic distribution is unequal in different countries, especially in developing country, between developing country and developed country. So we know the barrier and the benefit is very, there are many barrier and the or benefit. Through a qualitative study, we find the benefit of a particular model extend to the hospital outcome or the patient family outcome. Okay, so the patient family outcome include the compliance to the treatment or cost-effective or bereavement preparation. The full benefit in the proposition of quality care, the model must include constant appraisal and advanced care planning. So this is the palliative care's benefit. But we also could to find the barrier. If we could to provide the community palliative care community care barriers is include denial or rejection of diagnosis or poor knowledge and attitude of healthcare worker and no clear-cut policy on cancer or lack of manpower or default in check on appointment or cost of setting up and equipping palliative care team. So this is a barrier for to develop palliative care. So the barrier in daily clinical practice include like as such as the above I described. And then we would like to talk about the challenge on the to provide the palliative care in cancer in low and middle income country. This belongs to a systemic review papers. The aim is to find the challenge and how to provide the possible intervention. So we find the model is widely used in for the 4 level, from the personal level and the organization level and the health system level and the policy level. I think it's divided the 4 level from personal to the policy. So if we would like to provide or promote the public care in community, I think different level have a different strategy. So
we're very sorry, Prof.
Okay.
You have less than 2 minutes.
Oh, 2 minutes. Okay.
Thank you.
Okay. So the result we find this is the review. So we finally find. Okay. Connect to. Okay. So this is Indonesia. The barrier is lack of investment in health system, knowledge deficiency, and misunderstanding of hospital palliative care, and the difficult access to the pain management and the drug and the different geography. So this is different level have a different strategy. This is belongs Indonesia's country. So the challenge we have to provide different kinds, depend on cultural issue, religion issue, or the local issue to develop the appropriate care for the terminal patients. So this is a personal challenge, organizational challenge, policy challenge. Depend on different level challenge, we could do different strategy. So I think if everyone have the concept, is okay. So finally, we will like to introduce the quality of days. I think this is we could to skip. We could to there are many resources in planning home visiting program. So from staff or patient family financial issue or policy issue. Okay. So finally, we give the last share with you. The last data share with you. This is too much. Yeah. The recommendation from vertical integration, establish a comprehensive public care system, and increase awareness of public care in remote and rural area. The horizontal integration is enhance competency of family caregivers through training and increase access to public care through home-based mobile service. Okay. So this is a recommendation. So the nurse could to play different level role. Okay, to provide the appropriate days. So finally, we give you a reference. The good quality of good dying and the days from 2010 to 2021. The focus in past two indicator focus on inputs. The last days, the last indicator focus on added output, include the another indicator. The another indicator include the economic issue. So while the HDI or the economic issue is very important, this is Taiwan was ranking the 3rd in the world for the good days. Okay, the Indonesia. The Indonesia was ranking in 15.1. Yeah, it's improved because the Indonesia's indicator upper middle income and the score is 60.5. Okay, so congratulations because the Indonesia improved. Less than 2025. So the keep going. I think it's very, very excellent. So the high correlation between good days with the GDP or HDI indicator, or in the other economic indicator. So we know if we would like to get the good days, very significant with the economic level. So economic is very important. So, but finally, the conclusion is viable home visiting require palliative care team to carry out the service and the hospital policy to direct their activities. Putting this into practice will be in line with the WHO advocacy of integrated palliative care for the chronic disease. And finally, the challenge is implementing palliative care. We know we have to be overcome by established workable model and policy allocating adequate funds and appropriate monitor of palliative care activities. Okay, so this is my share. Yeah, thank you.
Thank you very much, Professor Hu. Maybe we can sit together on the stage, and here I'm welcoming to Dr. Tip and Professor Supriyatno to also joining us on the stage. We'll be having discussion. Okay, once again, maybe we can give another round of applause to the speakers, and also Professor Chuang. Yeah, we all here. Okay, thank you so much for all of our 4 speakers. Moving on, we will be having a discussion with the participants. Any of you, if you have any questions, you can straightly raise your hands. But before, please allow me to ask you all one thing, because generally in cancer, we know that the main problem is about late diagnosis. Thus, the late diagnosis will lead us to bad treatment, then maybe bad palliative care to the patients, right? So, what I want to ask to the 4 of you, where are we now? Are we going to a better direction? And maybe, do you have any projections in the future, how we can collaborate together to the better diagnosis, better treatment, palliative care for the cancer patients? Okay, that's my question to all of you. Maybe who wants to answer first? Dr. Tip?
，Okay. So for me, I think for the brain cancer, actually we use the solid tumor, right? It means that it's already late, right? But in the future, I am thinking about cell-free DNA. Yeah, it's kind of get the sample from blood, yeah, and then do some monitoring or try to detect the marker, for example, brain cancer biomarker from the blood. Yeah, this is what I think, and maybe in the future trend also. But still, we can use nanopore technology to do that. Yeah, this is what I think.
Thank you, Dr. Tip. Next up, Prof. Supriyatno.
Thank you, Dr. Aga. Maybe in Indonesian about oral cancer, why the patient is too late to the hospital? Because in oral cancer there is no symptom and sign, only smooth, so no sign, no symptom. So I think with the no symptom and sign, So the patient still keep in home, in house, not in the hospital. Yeah, I think from Professor beside me is right. That brain cancer or oral tongue cancer is a solid tumor. So I think we can use the biomarker to find, maybe to diagnose, or some differential diagnose. Maybe you can use a biomarker, especially in oral cancer. And then maybe there's a reason why the patient in Indonesia led to cure the oral cancer. First, no symptom and sign. Two, maybe it's very expensive cost for treatment oral cancer. And then maybe too far, the hospital, especially cancer institution, too far from the patient. I think that's all of my reason. Thank you.
Thank you very much, Prof. Supriyatno. And maybe Dr. Chuang, you can give your opinion about this. Where are we now in detail about the treatment of the cancer patient?
Yes. Development of normal methods for cancer diagnosis and cancer treatment is always necessary, and that can bring a lot of benefit to human beings. For example, in the past, there are only three standard treatments for cancer patients. One is surgery, and the one is radiation, and also chemotherapy. But in the past several 10 years, we witnessed the development of cancer immunotherapy. The development of therapy with immune checkpoint blockade is another become another standard treatment methods to the cancer patient. But still, the immune blockade therapy is only effective to about 20 to 30% of the patients, and it's also required for precision diagnostic to determine what type of patient is can be benefit from the cancer immunotherapy. So development of normal methods for cancer therapy and diagnosis is always required. Okay.
Thank you, Dr. Chuang. And maybe from Professor Hu, maybe you have insights on what we can collaborate on from the early diagnosis on the treatment and the final palliative care to the patients of cancer.
Okay. I think every patient, if have any sign symptom, would like to go to the hospital to seek to get treatment or get treatment. But sometimes they are initial stage, the first stage, and maybe he come to hospital is the late stage, the terminal patients. So I think maybe would like to depend on the patient and the family. The medical staff would have to communicate with the patient and the family to let the patient have, to use the shared decision-making model to communicate with them what is appropriate for them. Because due to different country, different economic standard. So I think maybe sometimes the treatment is so the price is very high. So the maybe is very burden for the family. But from the ethical issue, maybe the social worker or would like to help them. So I think maybe appropriate care for the patients, the holistic care. I think the interdisciplinary collaborative to communicate and share the decision making to do the final decision by the patient is appropriate. And then I think maybe interdisciplinary communication and education together is very important. Yeah.
Correct. I agree with all of our speakers. To fight cancer, we cannot do this alone, right? We have to do this together because there are a lot of aspects going on in this particular disease. Okay, now moving on to the participants, and I notice here that we have a variety of participants. We have some fellows from Europe, we have some fellows from Asian, and from the perspective of our speakers and where we are now, we are talking about all the things cancer in Asia, right? Maybe the fellows from Europe, we can hear some stories from where you come from. If I'm not mistaken, a lot of you come from Netherlands, right? Maybe you can share to us about the cancer treatment there, about how the citizens there got their treatment. Are the doctors treating the patients better, do you think, rather than in the Asia region? Maybe any of you want to share your experience in Netherlands, please? Yes, you can use that mic.
On?
Yes.
Well, I think in the Netherlands, it really depends on what type of cancer you have, because there are a lot of different options, treatment options. Yeah, I think shared decision making is very important. So I think the oncologist explains the treatment possibilities, and then together with the patient, you decide whether or not you get a chemotherapy or radiotherapy. I think that's a very important part about the cancer treatment in the Netherlands, right? Because it depends very much on your age, where you come from, what is important for you.
Do you think in your country the procedure of getting treatment or getting bed in the hospital is much easier rather than in the developing countries?
Yeah, maybe. I think that cancer is a very common disease in the Netherlands. So I think there's a lot of attention for it, and people take it very seriously. And we also have a lot of screenings for cancer. And I think there's a lot of attention and time and money going into cancer research and cancer treatment. So yeah, I think it is.
Oh, this is interesting. I think excuse me, what's your name?
Eva.
Eva. When Eva said that there are a lot of screenings happen in Netherlands, it's like I haven't even had any screenings here in Indonesia. Maybe Dr. Chuang, Dr. Thip, any experience in Taiwan or in Thailand?
So in Thailand, we also now start to have like a screening. Yeah, but people who want to do screening have to pay by themselves. But let me add about Netherlands. So in May, I went to London. Yeah, for London Calling Nanopore conference. And I met one person, professor from Netherlands. He used nanopore to detect the methylation from the brain cancer tissue. And then within less than 1.5 hours, and then go back to the surgery room and then can say that, oh, remove the tissue. Yeah, how big, how small, something like that. And after that, last month, he published in Nature. Yeah, that called intraoperative. Yeah. So it's like the way that they detect the cancer cluster, the cancer, classify the cancer is faster than Asian country. Yeah, the way that he tried to do. So this is when I show to my boss the paper, that why don't we do something like this? Yeah, and then he said the way to do surgery is different. Yeah. So in this case, we have to think about it's not just the detection. Yeah, it's not just the classify, but we have to work with the clinician, work with many people. Yeah, so good for Netherlands.
Yeah, I do think I haven't really heard about it that this is happening in the Netherlands. So I do think it's a new new technology, because right now I think you still have to wait a few days before there are any results and stuff. But yeah, good thing that it's coming then.
Thank you so much for
You're welcome.
sharing
Thank you.
stories. We can give Ava applause too. Okay, now open to the floor. Please, if any of you want to ask to the speakers anything, or maybe another story sharing. Oh, okay, please.
Testing. Good morning. My name is Shahir from University Science Malaysia. I have two questions. The first one is for Prof. Kit regarding the Smurf technique that you explained just now. Is there any possibility that because in Smurf technique there is the cut and recombine between different length, different segment of chromosome, right? Is there any possibility of misreading the sequence, or do you have any data that shows that using Smurf or using Smurf has no difference in possibility of error compared to using the usual long read sequence? The second question for Prof. Wen. May I know what is the view of Taiwanese people regarding euthanasia? And then may I know what is your suggestion if let's say in countries such as us, Muslim majority country, there is euthanasia is illegal. So what is your suggestion about counseling or further action if patient requested for so, or in any country where euthanasia is illegal? What is your suggestion regarding counseling or further action for the patient? Thank you.
Okay, thank you for the great question. For the Smurf seed, actually when the enzyme cut, it's not like it's random. Yeah, it's maybe 600, 1,000, or even 20. Yeah, but what we try, we map, and the base map will be that region. So it's not mapped to many places. We choose the best one. The idea, how can we make sure we try on different cell lines first, that we know the result. Yeah, when we get a good result, then we move to the next step. This is what we try. Yeah.
Do you have any follow-ups on that? No? Okay. For the second question, please, Prof. Hu, about euthanasia. What do you think about euthanasia and in Taiwan specifically? No, in Taiwan first. What do you think about euthanasia in Taiwan?
In Taiwan, we have the Public Care Autonomy Act. So we promote the natural death. Do you know what I mean? Because my means is we promote the advanced care planning. The advanced care planning means is when the patients the disease become more and more the disease is rising or decline, and then the patient and the family will discuss with the family, the physician. The physician and or social worker or nursing will give the advanced care planning to provide more information to them, and then they could to decide which treatment is better for them, and they can to choose appropriate treatment. And the law, the regulation is the National Autonomy Act. So it's from 4 years ago, we start to do it. So we promote the natural days. Yeah.
Is it one of a popular option to the citizens in Taiwan?
Okay. Initially, the family always would like to let the patient to treatment to the last day, the final minutes. But gradually, they found that the suffering, the effective treatment for the patient is suffering. And then the medical staff provide the palliative care. So the patient have the opportunity to ventilation and to express their opinion. And then so gradually we educate the family. So the family more and more to agree the DNR. So the percentage more and more increasing. Yeah.
DNR do not resuscitate there. Okay. 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 Another question, please.
Okay, good morning. My name is Nurul Huda binti Musa from Malaysia. Thank you to all the speakers for insightful presentations. I would like to ask Dr. Tidatip, because you have mentioned about probably in future we can use the blood biomarker to do the CPG methylations analysis. Because you have used the brain tissue to get your sample for the analysis, do you think the CPG and the methylations result will be the same from the tissue and in the blood? Or is it a really tissue-based analysis that we have to go with the tissue rather than use the blood to check on the methylations? That is my first question. And my second question to Prof. Supriyanto, you have mentioned one of the factors that cause oral cancer is the dental factor. I just want to get an idea how this like trauma, poor oral hygiene, chronic dental infections can lead to an oral cancer. Thank you.
Okay, yeah, great question again. So for the CPG, before I say about nanopore sequencing and get the methylation, previously in Europe, people use Illumina technology to detect methylation from patients. Yeah, it's almost 100,000 people already that they use. This is from brain tissue. Yeah, and then they use bioinformatics to classify those samples. Yeah, and then they can classify more than 180 group of the brain tumor. Yeah, so in this case, we have marker. Yeah, but for nanopore, we can sequence and try to overlap that marker to the known marker. Yeah, this is one thing. But we have to use the sample from tissue. Yeah, in the future. Now people talk about cell origin methylation. So it means that they study from brain, from different tissue, from blood, from white blood cell, from different things, and then try to see the methylation pattern of each cell. Yeah, then in the future, I think if we have good database on that, we can detect something. Yeah.
Okay. Do you have any follow-ups? No? Okay. And the second question
Yeah.
for Prof.
Thank
Supriyatno.
you for your question. Before I answer your question, I want to inform you that the treatment of the cancer not only monodiscipline, but multidiscipline. This is very, very important. Okay, so I think increase the oral cancer can be raised from something like oral hygiene, poor oral hygiene for the root of teeth, and then some infection. For example, hyperplasia candidiasis, for example. There is a big incident can be transferred to be malignancy. So the other cases, for example, many infection, maybe Dr. Aga, so from leukoplakia and then erythroplakia, leukoerythroplakia, somebody can is transformed to a malignant. This from infection because cancer can be promoted by infection disease like this case. I think that's his answer. Thank you.
Maybe this has a connection to with the TLR9 that Dr. Chuang has research on too, because TLR9, if I'm not mistaken, can be found on infection too. Maybe, doctor, are you following?
Yes. A part of oral cancer is caused by HPV infections. So right now there are some effort to develop vaccine for oral cancer. And the TOR9 agonist is a good adjuvant. So it is possible to develop the TOR9 agonist adjuvanted oral cancer vaccine to prevent the oral cancers. And the cancer vaccine is very succinct to prevent HPV infections for women. And I think right now in many countries, the young girl at junior high school level receive the cancer vaccine for the HPV infection, and that is demonstrated very succinct. And that kind of infection is pretty similar to a part of oral cancer. So yes, right now there is some effort to develop this kind of vaccine, and the TOR9 agonist is very likely will be a good adjuvant for this kind of vaccine. Okay, thank you.
Thank you, Dr. Chuang. The highlight is as an adjuvant, yeah, not the main ingredients, main component as the vaccine, right, doctor? If I'm not mistaken. Okay, Prof. Supri, please add.
Thank you. We have already experienced about oral cancer induced by human papilloma virus. In Yogyakarta, the main type of HPV is HPV 16 and 18. So we develop vaccine for this HPV. Thank you.
Thank you very much, Dr. Chuang and Professor Supriyatno. Any more questions from the audience, please? Do we have online participants? No? Okay. Oh, okay. No online question right now. What about the others from in auditorium? Okay, personally, I'm very interested in Professor Hu's lecture about palliative care because we have here a dental hospital and we have been in sometimes in developing like a procedure on giving palliative care to the patients, home care procedures, but until now we still stuck on how we deliver the treatment to the patients and some limitations on the tools, like how we bring the tools to the patients, like and how we can give good treatment to the patients. Maybe do you have any experience in Taiwan, like how to start giving home care to the patients?
Yeah, I think how to communicate with the patient or family about the death issue or terminal issue, and how to choose should die at home or in hospital. It's ethical dilemma 20 years ago in Taiwan. In hospital, we established the hospice care. Family, all the patients prefer to, I have to say, the family prefer the patient die in hospital. So, but when the family go back home, the patient always say, I would like to go back home, to die at home. So this is ethical dilemma for the medical staff. Initially, we start the workshop for provide the workshop to the physician and nurse and the social worker together to play and role play in some situation how to telling the truth. And the government also give me some money, some funding to design a guidebook to how to telling the truth. And when how to promote or prepare the family or patient could to choose die at home. We initially we start to training the palliative care home care nurse, hospice home care nurse. Yeah, so we provide the hospice nurse in palliative care many years experience and they have full experience, rich experience, and then she could to provide palliative care at home. So when the patient before the patient discharge, the home care nurse will discuss and communicate with the patient and the family how to prepare their family, how to setting the family environment, and then the family and the patient go back home. When they have some needs and the necessary, they could to call the home nurse. There are 24 hours on call. Yeah, but we could to educate the home care nurse. They have to prepare the patient before they discharge. So few on-call, few call on the night. So, but sometimes they have to use the drug or medicine, and we will consult our physician. They will go to the home, yeah, to visit the patient, and then to give some drug, yeah. So gradually, the patient and the family could to go back home, yeah.
it's very insightful, but still, I think here it's still quite a long way to go, because we cannot do that without any enough support, right? We cannot ask the nurse to stand by 24/7 without any financial support.
Yeah.
Yeah. Okay. Okay, please. Any other questions? Okay, maybe Dr. Chuang or Dr. Tip, Prof. Supriyatno, Professor Hu, any other closing statement, closing remarks before we end this session? Dr. Chuang, maybe you want to say something?
Okay. I just say the development of novel diagnosis and therapeutic strategy is always required and can benefit human being for cancer treatment. But if there is no any major breakthrough in therapeutic methods, then combinational therapy is a major trend for cancer therapies. Based on what we know right now, we can bring different therapeutic agents together and use rational design to combine different functions we want for a better cancer treatment. Okay, thank you.
Thank you very much, Dr. Chuang. And this is the final statement from Dr. Chuang to end our cancer panel this morning. Thank you so much to all of our 4 speakers for the amazing lectures. Please give applause once more. And thank you so much to the participants, to all of the questions. We hope we can benefit this to all of you. And I'm giving back the event to Mas Yopi. Thank you, Mas Yopi.
Okay, once again, give applause for Bu Ayu from Faculty of Dentistry, Faculty Universitas Gadjah Mada. So can we take a photo together in the center of the stage? Mas Aryo, can you help me to take a photo? Okay, guys, that was the 4th panel for the summer course 2023. For participants who join online, we will be back on the lecture sessions around 12:30, so you can grab some lunch. And I have some information regarding for the drop-off in the Puskesmas for the tomorrow agenda, so make sure you pay attention, everyone. So first, you have to attend at the lobby auditorium at 7:15. First, you have to attend at the lobby auditorium at 7:15. Make sure. Datang aja, okay. Make sure for the overseas students you bring all your belongings because you will stay in the Puskesmas area. Okay, I repeat again. 1, you have to meet at the lobby auditorium at 7:15. Bring all your belongings for overseas students, okay? And we will go to the Puskesmas using bus divided into 4 groups. And we will go to the Puskesmas at 8 a.m. the Puskesmas. Okay, and also for the national students from UGM, you also going with us using bus or you can use your own vehicle. But if you're using your own vehicle, please give the information to Mbak Mita or Mbak Reni. Okay, you got it? Yeah, that's the information. Okay, and for the Sunday, November 12th, make sure you already wash your summer course t-shirt and wear it for the outbound activity. Okay, that was the information, and I will give the adding information after you enjoy the lunch break. And we will be back at 12:30 for the last panel for the lecture session. Enjoy the lunch, everyone.